Welcome to today's Steps Forward webinar on prediabetes in partnership with the Center for Disease Control and Prevention. Thank you for taking your precious time to learn more about this important topic and how we can identify and treat this condition efficiently during a very busy clinic day. We're going to focus on teamwork, simple changes that you can implement this afternoon or tomorrow, and become inspired and reconnect with the purpose and pleasure of practicing medicine. Let's quickly review disclosures. This webinar is supported by an agreement with the CDC, strengthening public health systems and services through national partnerships to improve and protect the nation's health. The contents are solely the responsibility of the authors and do not represent the official views of the CDC or the Department of Health and Human Services. This presentation will also include a discussion of Metformin for prediabetes, and this is a non-FDA approved off-label use of Metformin despite high-quality evidence of efficacy and safety. I will be including my comments about the clinical scenarios with my colleague and medical assistant, Veronica Garcia. I'm Marie Brown, an internist practicing in Chicago for over 30 years in a variety of settings, including an FQHC, a small two-person practice, and a large integrated health system. During this webinar, I'll give a brief overview of prediabetes, including definition and impact, but most of the webinar will be focused on time-saving solutions to help you identify patients with prediabetes and intervene early. We'll provide you with resources to assist in this task, showcasing tools from the CDC, the American Diabetes Association, and the AMA stepsforward.org program, all free, open access, and provided at no cost. Hopefully, by the end of the webinar, you'll be able to implement time-saving changes during your next clinic. Briefly, we know that 1 in 3 adults have prediabetes. That's an enormous number. But only 15% of patients with prediabetes have been told by their provider that their blood sugar is consistent with prediabetes. And this is not because you listeners are unaware of the importance, but more often because you don't have the time to address the hundreds of guidelines expected of us to address in the 20 minutes you might have with a patient. Hopefully, we'll provide you with some resources to save time so that you can efficiently deliver this message and identify those patients with prediabetes. We know prediabetes is common, easily diagnosed, and treatable. But how does this screening for prediabetes present in a busy physician or provider's day? Well, this would be a typical patient in my practice, a busy internal medicine practice. I'm already 35 minutes behind. I have 100 messages in my inbox. I looked at my quality measures and they're all red. The patient is a 40-year-old woman, teacher, mother of 4, very busy lady. Her blood pressure is elevated. Her weight is up. She's gained 5 pounds since her last visit. She eats most of her meals on the go outside of the home. And she doesn't feel like much interest in doing things. She's feeling a little lethargic. Her history includes obesity, depression, hypertension, hypothyroidism, some arthritis. She's physically inactive. Occasionally, she complains of insomnia and anxiety. And her meds include a beta blocker, an antidepressant, a sleeping pill, thyroid, and some contraception. Pretty challenging patient to address all of her issues, all these medical conditions in 20 minutes. But we also notice that in her history, there's no prediabetes because we haven't had time to screen for it. So first, let's take a quick review of the definitions. Prediabetes is most often diagnosed with a blood test called an A1C, if the level is between 5.7 and 6.4. This reflects the average blood sugar over the past 3 months, given the hemoglobin is normal and the red blood cell survival is normal. It can also be diagnosed with a fasting plasma glucose or a 2-hour OGTT. The U.S. Preventive Services Task Force recommends that we screen for prediabetes and type 2 diabetes in all patients between 35 and 70 who are overweight or obese, which is going to include the majority of my patients. In addition, the Standards of Care in Diabetes 2023, which are open access as well, list the criteria for screening at an earlier age if the patient has what's listed here: family history, PCOS, gestational diabetes. We also want to highlight that people with HIV should be screened for diabetes and prediabetes regularly and when changing medicines. So let's get back to our patient, Ms. Hernandez. You do what you can, try to meet the gaps. You order an A1C because the last one you have is or you don't have one because she's not diagnosed with diabetes or prediabetes, but now you remember that she had this, she meets the criteria for testing prediabetes, but she wants to stop her blood pressure medicine, and she's interested in losing weight. And then you remember that you just saw this webinar and you're reminded to screen for diabetes and treat her obesity. How does that make us feel when we don't have time to meet her needs? She reminds us that she needs a mammogram and a pap smear, a handicap parking sticker, et cetera, et cetera. Pretty frustrated. So the challenges facing many clinical teams are numerous. There's a growing volume of chronic disease and a lack of time to effectively deliver uninterrupted attention to our patients, which is what our patients want. We need to address social drivers of health as well. This graphic is taken from the AMA's Health Equity Plan, which is linked to the resources at the end of this webinar. Patients' social needs refer to their individual level resources and circumstances required for well-being in their community. Social determinants of health address the underlying community-wide social, economic, and physical conditions in which people live, eat, work, play, and pray. The AMA is committed to working upstream to address all determinants of health and root causes of inequities. And if you work in a health system, we know that there are many challenges here as well. We're held accountable for performance measures, emergency room and hospital utilization. So there's so many competing priorities. And in addition, if you're family practice or internal medicine, there's about 1,600 guidelines that we need to address in about 17 minutes. Can leave you very frustrated. So that's the big picture of the external environment, including feeling some clinician isolation, increased patient expectations, especially post-COVID, number of patient portal messages coming to us. But we can do something about that if we think a little bit more efficiently. So let's see what a visit with Ms. Hernandez would look like without a team. This is the same slide, and we can see that in those few minutes, I can't accomplish what I need to. If you asked your teams what they would do first, here might be a list. She needs her depression addressed. We need to review whether she needs some of these medicines or we could change them. We need to order some lab tests. Many, many things need to be done in a very short period of time. What happens with Ms. Hernandez between this visit and next? Well, many things will occur. She will have to call for the results. You'll have to reach her for the results of the tests. And you can see that this is very inefficient, and these touches will interrupt your ability to care for the patients in your visit in your clinic that day. And what is the cost of all this? Well, it's a minute here and a minute there, but if you add it all up, it can be an hour between visits or 3 hours a year for just one patient. And this is just not sustainable. At the AMA, our strategy is to help remove obstacles that interfere with patient care. Next slide. We put many of the time-saving approaches into a saving time playbook. These are highlights of 70 toolkits that have been developed, led by Dr. Sinsky, myself, and Dr. Jill Jin, with wonderful contributions from authors all over the country sharing best practices. And again, these are open access. But often when we talk about these opportunities, when we're talking to our colleagues, this is what we hear. And this is where I'd like this slide to show. Quite often, everybody is so busy that they can't even think about changing anything until we take something else off their plate. So if you look at the Saving Time Playbook, the first thing we do is suggest stop doing unnecessary work. And there are many opportunities to get rid of unnecessary work. It could include simple things like reducing alerts, simplifying the order entry processes. We have a toolkit called Getting Rid of Stupid Stuff, or if you don't like that phrase, getting rid of waste. And we need also to stop over-interpreting many of the rules and regulations that we all need to live with. With help from our colleague, Dr. David Baker, an internist and executive vice president at the Joint Commission, he reminded us that organizations frequently establish stringent requirements well beyond our standards. And when the Joint Commission visits your site, they are scored on whether they are following their own policies. He states we get blamed for this, and that's how myths arise when we require things when we do not. So often it's helpful to go back to the source, and we do have a website called Debunking Regulatory Myths to make sure we don't waste time over-interpreting the rules or shooting ourselves in the foot. We've compiled many of these in the de-implementation checklist. You can find tasks that do not add quality to the patient experience, the provider, or the organization. And if you stop doing these, some of these unnecessary tasks, you can save an hour a day per provider, which could be 30 days if you add it all up over the course of the year. And often asking the providers themselves what they think they are doing that is unnecessary, wasteful, or duplicative is a very good place to start. And we show you how to do that. Because often the physicians themselves are the best, in the best position to find these unnecessary tasks, as well as all the other members on your team. And I also remind patients to do this work. Don't think like a clinician. Nurses, physicians, PAs, APPs have all been trained to think of the exception. But when we're trying to look at efficiency, we don't want to think of the exception where it wouldn't work with one or two patients, but where it would a change in flow or a process would work for the majority of patients. We want to think, again, next slide, like an efficiency expert. Here's a list of things you can stop doing. There's a link to this information on the last slide as well. I'm now going to introduce my colleague and friend, Veronica Garcia, a fantastic medical assistant that I've had the opportunity to work with for over 10 years in my primary practice. She's also teaching at our local community college in Chicago. She will share the value of team-based care and how important teams working efficiently together is valuable for both the patient experience as well as your team. Veronica?
Hello, and thank you for giving me this opportunity to discuss some practices that result in better quality care, outcomes, and additionally save time. They also give every member of the team more joy. I first want to discuss the importance of pre-visit planning. I can accomplish all the production work, freeing the provider to address what we call solution work, diagnosing a new problem, building trust, increasing adherence, etc. Health maintenance orders include mammograms, colonoscopies, and immunizations. If a patient has diabetes, it would flag that their A1C is due. Another part of pre-visit planning is going over the patient's medications, making sure that the medication list is accurate. If they need any refills, this is where we would be able to pen orders. This depends on your state and local policies. It saves so much time in the long run if this is handled correctly up front. It's a trickle effect, and it's something that can be prevented with pre-visit planning. Pre-visit planning includes pending any labs that are due following standard orders, such as A1Cs. If you know you have a patient with diabetes, it's been over 3 months, you want to make sure you pen the order for the A1C following local standing orders. All these little things help so the doctor gets to spend more one-on-one time with the patient. That's just a few of the things I wanted to cover that really help save time so the doctor stays on track with the patient. I like being more involved, and the patients appreciate that their concerns are addressed quickly and they're seen on time. There are toolkits within Steps Forward to help implement pre-visit planning and team-based care and manage the EHR inbox.
As Veronica stated, pre-visit planning is of key importance to efficient workflow, but you need to provide your team time to be able to do that pre-visit planning the day before or a couple days before. This can take up to an hour the day before, but that 1 hour can save 3 hours. In addition, team documentation is a great time saver. And because we've all been busy with COVID over the past few years, many of us may not be aware that the rules have changed. The House of Medicine fought hard for this change, and we can count on our team and patients doing much of the documentation that providers so that providers are able to give their patients their uninterrupted attention, focus on solutions, and developing a differential diagnosis, motivating patients and increasing trust. This is taken right from the .gov website. We know that we are no longer required to re-enter information in the medical record regarding the chief complainant history, and this can be reviewed and verified. I encourage you to dig deeper into this new regulation because it's a tremendous time saver. We've just highlighted a few changes that you could implement. Listed here are the pre-visit labs, prescription management, moving from writing chronic meds from 90 days with 1 refill to 90 days with 4 refills. Looking at your inbox and team documentation, adding these all up can save 3 to 5 hours a day. And what do you do with that extra time? You finish your work at work, you have more uninterrupted time with your patients, and more time to work with your team so that you can find other opportunities for efficiency. Let's get back to our patient, Ms. Hernandez. How do you know if she's ready to lose weight? In the Annals of Internal Medicine in the clinic, one of the first 2 things that you want to do is make sure she's free of untreated major depression and not in the middle of a major life event before we start asking her to address her weight issues. The ADA 2023 standards include referring all patients with prediabetes to an intensive lifestyle behavior change program modeled on the Diabetes Prevention Program, the DPP. Production work like referrals for the DPP is handled by standing orders, so the physician doesn't have to think about it. If my team sees prediabetes on the problem list, there's an automatic referral to the local DPP. And I'm going to turn it back over to Veronica because that's what I expect her to do, and I don't have to think about it, and our patients get great care that way. Veronica?
As an MA, one of our responsibilities, according to standing orders, is to refer patients with prediabetes to the nearest CDC recognized organization offering the National Diabetes Prevention Program, or National DPP Lifestyle Intervention. The National DPP Lifestyle Change Program is an evidence-based, year-long structured program that helps adults at high risk make sustainably healthy changes to prevent or delay the onset of type 2 diabetes. I'm now going to hand it over to Madeline Brady, our AMA colleague, to talk a little more about the National DPP.
Thank you, Veronica. Hi, everyone. I work in AMA's Improving Health Outcomes unit, where we aim to help prevent cardiovascular disease. I'm going to share a little bit more info about the National DPP today. So helping the patient take the first step is important, which includes knowing where to find the National DPP delivery organization in their neighborhood or virtually if that's what they prefer, and then how to enroll. You can locate your nearest National DPP delivery organization in your area by going to the CDC's Find a Program website, as you can see on this slide. The site also includes organizations that offer the program online or through distance learning. There are eligibility requirements to enroll in the National DPP Lifestyle Change Program. First, all participants must be 18 years of age or older. They must have a BMI equal to or greater than 25 or 23 if Asian American. The patient must not be diagnosed with diabetes and must not be currently pregnant. The patient then needs to either have a blood test within the past year showing results within the prediabetes range, have a previous diagnosis of gestational diabetes, or have an elevated score on the CDC and ADA prediabetes risk test. The National DPP Lifestyle Change Program is led by trained lifestyle coaches and is offered in a group format that provides an opportunity for strong peer-to-peer support. The lifestyle coaches use an evidence-based curriculum with oversight and quality assurance provided by the CDC. Achieving and maintaining recognition by the CDC requires regular data submissions that include participant outcomes such as weight loss and A1C reduction. The National DPP Lifestyle Intervention is increasingly being covered by more and more payers. However, there's still a lot of work to do in that space. There are 22 states in the District of Columbia that have achieved varied levels of Medicaid coverage. The link to find out more specifics is included in this presentation that will be available on our website. There are also some commercial payers that cover the National DPP, which we will also include. And lastly, there is a Medicare Diabetes Prevention Program, known as the MDBP, that allows Medicare beneficiaries to access the program. MDPP suppliers are part of the National DPP and can be found on the CMS website. With that, I'm going to hand it back to Veronica. Thank you, everyone.
Thank you, Madeline. As you can see here, inside all our exam rooms, we have an emptied bottle of soda that has been filled with the amount of sugar that each of these beverages contain. It's definitely an eye-opener for the patients and or their family members. It's very impactful. I'm going to go ahead and pass this over to Dr. Brownell.
So we can't stress enough how important lifestyle change, diet, and exercise is. And hearing that message in the doctor's office with that little bottle of sugar and reinforced with attendance at the DPP program is critical. In addition to lifestyle changes, we want to consider metformin, though this is not FDA approved for diabetes prevention, but it is especially useful in patients with a BMI over 35, under 60, and women with a prior history of GDM. So metformin has been around for hundreds of years, originating from the French lilac bush. It was shown in the original DPP research trial to reduce the incidence of developing diabetes by 31%. It's very inexpensive, very well tolerated if you take the time to learn how to titrate it up slowly to avoid the diarrhea that many patients often experience. If you stay on the metformin for as briefly as 7 days, usually the GI intolerance does resolve. As a reminder, it's not approved by the FDA for use in treating prediabetes. However, that doesn't mean it can't or shouldn't be used. The AMA PreventDiabetes.org website has numerous tools to help you find the best options for your patients with prediabetes and lower their risk. The FAQs are very helpful, and I strongly encourage you to look at that if you're interested in learning more about how to do this efficiently. Go to this website and look at the tools. They're designed by our Improving Health Outcome team here at the AMA. So let's finish up by talking about Ms. Hernandez. This is an overview of what we started at this webinar talking about. Numerous issues, numerous concerns that we need to address, as well as numerous concerns that we may not have time that she wants to share with us. With pre-visit planning, where Veronica takes time the day before, with a team, I have everything I need to care for her at the time of the visit. So with practice redesign, the visit would be quite different. My staff called her yesterday and set the agenda, asking her what she wanted to talk about. We have all the pre-visit labs ordered. She's already been to the National Diabetes Lifestyle Program, and all her questions about diet and exercise have been answered, and she's been highly motivated. All the refills were handled several months ago, and everything I need to care for her that day, I have on hand. This is a completely different experience. Between this visit and 3 months from now, all of these things that would have happened without team-based care and without practice redesign are not going to occur. So with each patient, you're saving back all those, you're avoiding all those interruptions between this visit and the next visit. Our first goal with a patient with obesity is not to gain weight for 3 months, not necessarily to lose. And then we have time to celebrate that she didn't gain weight and then move on to trying to lose. And the next time we see this patient after the first visit with practice redesign and 3 months from now, she's been several times to the program. She's been to the physical therapist and has lost some weight. Your staff called her yesterday for only a few minutes to set the agenda. And everything is going along much better, and blood pressure and sugar levels, weight is all heading in the right direction. I hope you see the benefits of looking at ways to improve efficiency and using some of the open access tools we presented for you today. And how does this make a provider feel if she's heading in the right direction? This young woman who has a big family at home, we can celebrate and you feel almost as good as she feels. So again, we have 70 open access tools. They're divided into clinical issues, EHR, burnout and well-being. We've highlighted just a few of them for you today. These are how-to toolkits, actionable, relevant, that you can learn something today to apply this afternoon. Here's a list of some of them. We have several on immunizations, addressing vaccine hesitancy, medication adherence, preventing burnout, improving resiliency, and really bringing the joy back into this wonderful, wonderful profession that brings us all together here today. This is one of the toolkits, and with Veronica here, who also helped us write, we have a toolkit on, given the workforce shortage, medical assistant recruitment and retention. And she, as a faculty member at the city colleges, is helping with that as well. And I'd like to end by this next slide. The principal driver of clinician satisfaction is delivering quality patient care. That gives us tremendous joy, and that's what our patients need from us as well. It's a very, very rewarding profession, but we need time to accomplish it. So our take-home points are: think about embracing team-based care, start with pre-visit labs, expand it to pre-visit planning. You'll have time to identify patients with prediabetes and prevent them from developing diabetes. Use a lot of standing orders, including those to get you to their local NPP. Stop and replace medication that we may be giving that can cause weight gain. Treat depression and assess for it first, and mutually agree on the goal. First, no weight gain. Consider Metformin for those eligible, and then really celebrate success. It'll make you feel good, and it'll make your patients highly motivated and ready to come back and tackle maybe losing another 5 pounds and maybe walking a little further each day. These are several additional resources with links. All of these are free and open access. Your email is not even required for most of them, especially those of the AMA. I thank you for your time and hope you'll tune in to another webinar coming up soon. Thank you, Madeline and Veronica, for sharing your wisdom as well. Have a good day.
Good afternoon, everyone. Thank you for joining Dr. Brown and me live to answer some of your questions. If you would like to ask a question, please feel free to put it in the Q&A box located on your video player. For now, we'll get started with several questions that came in from the registration page. First, we have, what action steps in the clinical workflow connects the clinical team to national DPP provider options for patient referral? I can take that one. So it's always best to start looking with your EMR. What can you optimize? This includes creating reports or creating registries to track your patients that have documented prediabetes. From there, you can either do bulk or individual referrals. As you heard Veronica mention on the webinar, at her site, it was her job as the MA to make the referral to the national DPP. However, every healthcare organization handles this a bit differently. You're able to find more resources and tools for the team on amapreventdiabetes.org. The next question we have is, you suggest pre-visit labs. However, do patients mind coming in for a separate visit to get their lab work done? I'll
take that one.
Dr. Brown.
That's a great question. And when I first saw the literature on how much time could be saved, my reaction was the same, that my patients would not want to come for a separate visit. And I implemented this in my 2-person practice about 8 or 9 years ago. But I believed the literature and I gave it a try. It's always good to start with a little pilot. Generally, my patients absolutely loved it. They did not mind coming in a week before at their convenience for their blood work, because the visit when we were together and face to face then was so much more meaningful. We had the thyroid, the TSH level, we had the BMP, we had the A1C, and we could make changes or think about, well, is it out of our, is it not at goal because we're not taking our medicine? Instead of escalating therapy when in fact it was a medication non-adherence issue. So it doesn't work for every single patient, but in my practice, it worked for about 95% of patients. And often they even went to a lab closer to home. So it really wasn't out of their way. And they really appreciated not having those days after the visit to play phone tag. Because nowadays, who answers their phone, right? So I was pleasantly surprised, and I hope that will be your experience as well. That is the experience for most people around the country. When you implement it, it's important that the whole team understands what you're doing, including your receptionist, because the first time you do this, it will take a little bit more time because you're ordering labs for today. And now we're saying, and get your labs a week before your next visit in 3 or 6 months. So they're leaving with 2 lab forms. And the receptionist needs to understand that as well. Sometimes writing out a brief 2 or 3 sentences to explain to the patient why we're doing this is helpful. But it saved probably an hour or 2 a day, just that one intervention.
Okay, great. Thank you. Next question we have, why is it important to screen for depression in patients with diabetes or prediabetes?
Well, it's clear that people who have diabetes and obesity have a higher incidence of depression. And you know your patients. It is more effective to make sure the person's depression is treated appropriately, or at least identified, before moving on to adding a lifestyle change that they may not be ready to tackle. So telling someone who's already depressed, your one message that day is that they're 30 pounds overweight is probably not going to, that probably will add to their depression. It's also important to ask the patient, what do you want to work on? Shall we work on treating how you feel and your energy level, or do you want to work on your weight loss? And most people will say, let me get my energy back to normal, And then all those other things, their activity level, their choices, because we know a sign of depression is being able to make choices, right? So treating depression first is more important generally. So we want to make sure that that's treated, and we're using medicines that don't add weight gain.
Yes. Great. Well, just a reminder, everyone, you can submit questions in the Q&A box. A few other questions that came in. My practice does not use standing orders. Are these orders allowed to be entered by a non-physician?
Well, this is what the Joint Commission has been very clear about. So you want to set policy, you want to set that is agreed upon by all the team members, and you want to have a process where you review it regularly. So if the process is reviewed regularly and you have standing orders, again, each organization may vary, but many organizations find tremendous efficiency by following standing orders. And as Veronica said, the routine production work is automated so that the physician, the clinician can have time with the patient to talk about issues. Maybe it's depression, maybe it's motivation, maybe it's non-adherence. So standing orders seem to have gone by the wayside over the years when the EHR came in, but they are extremely valuable and should be applied so that we can get, so we can be consistent and make sure that every patient who's eligible is screened for prediabetes, and every patient with diabetes has everything available to them as well to provide them a healthier lifestyle.
With that, the next question is, what is available reimbursement and coding for identification and screening for diabetes prevention? And I'm happy to take that one. That's a great question. So we actually have a one-pager on this that lists all of the appropriate screening codes on AMA Prevent Diabetes under tools and resources. It's also linked in the toolkit that this webinar features. And then I'd also like to add that thanks to AMA's advocacy efforts, the 2024 proposed Medicare physician fee schedule includes coverage for A1C screening test for prediabetes. The final rule won't be issued until later this November, but we don't expect this to change. So that was some great news. Next question I have is, you suggest ordering chronic medications for 12 to 15 months, but I like to give only 6 months so patients return for their 6-month visit, or for their visit in 6 months rather. What are your thoughts on this?
That is a great question. And once again, when I saw the literature at how much time could be saved and that it was safe to do so for most patients, I was a skeptic. And in fact, we just recorded last week a podcast called The Skeptic's Guide to 90 times 4. Again, pilot it with a few medicines, medicines that don't need monitoring, such as a statin or something like that. But using a patient's visit, insisting that providing only 6 months meds so that a patient will come back, I call that holding the patient hostage. We must make sure that the patient returns for their evaluation. Even though you're writing a prescription for 12 to 15 months, you're still seeing the patient as often as you need to. And in fact, you'll save so much time, you might be able to see the patient more frequently. So if you're backed up and a patient can't get in to see you for 6 weeks, saving 2 or 3 hours a day would allow you to see that patient more frequently. So the important issue here is you still see the patient as often as you and your patient need to be seen. If you're using the 90 times 1, only giving the prescription for 6 months, several things happen. The patient may miss a week, and so you're sort of encouraging non-adherence. But I understand that you're using it, and I was afraid of this too, that my patient might be lost to follow-up. What if they don't come back for a whole year? Well, those are two separate issues, right? Does your system, does your organization have in place a fail-proof system and a process to identify and reach out to patients who miss their appointment? That's how you want to handle that, not punish all of your patients and your team and yourself by writing for prescriptions for only 6 months. The second part of that is, in addition to that fail-proof system, when the patient misses an appointment, when your patient leaves today's appointment, is there a fail-proof mechanism to make sure that they make another appointment? Because if they walk out of that office, your office, without another appointment, whether it's 1 month or 3 months or 6 months, you won't even know that they missed an appointment because no appointment was ever made. So those two things need to be in place, and your organization needs to have a fail-proof system to make sure that's the case. And it's certainly so much easier with an EHR.
Great. We have time for just about one more question. Where can I find recommendations on treatment using metformin to treat prediabetes?
Oh, that's a great question. And I mentioned it in the webinar. Every January, the American Diabetes Association puts out a free, unabridged, abridged version for primary care for diabetes. And that is what I refer to every single year for treatment of diabetes. So that's where the recommendations and the use of metformin is directed. And I often show patients the literature. Patients like to see where this is coming from. And again, it's not approved by the FDA, but that does not mean it's not recommended. Mm-hmm. And it is the only drug that is recommended to help with preventing diabetes. And as we close out today, I just can't share how often how happy I have been when I helped a patient, like the patient I showed today, a 40-year-old with a big family, not develop diabetes at 50 and 60. And that's where I'd like to spend my time. And I hope this webinar was helpful for you and your team to think about the big impact you could have on a patient that we highlighted today. So thank you for your attention.
Thank you, Dr. Brown. And I'd like to thank everyone for joining us today. You will find a link to our toolkit below. And for additional resources to support your physicians and staff, please visit stepsforward.org and amapreventdiabetes.org. You will all be receiving a follow-up email thanking you for joining us today that will include a link to a brief survey. Please take the time to fill this out as your responses help guide our upcoming programming. Part 2 of this webinar series featuring the prediabetes quality measures will air on November 14th in honor of World Diabetes Day. If you have not yet registered, you can do so at the link in the chat. There is also a QR code in the corner here that you can scan to register. Thank you again for joining us, and we hope to see you again soon.